اتفضل يا دكتور.
بسم الله الرحمن الرحيم. On behalf of the board of the Egyptian Society of Diabetes and Lipidology, I am honored to start this meeting, which is a collaborative meeting between the Egyptian Society of Diabetes and Lipidology and the Cardiovascular Working Group of the European Society for the Study of Diabetes. The meeting will discuss diabetes guidelines implementation in the next 2 hours summit. And I am honored to present Professor Antonio Ciriello to have an introductory word for the audience as a representative of the European Society of the Study of Diabetes. You are welcome, Professor Ciriello.
Thank you for the kind words, and good evening to everybody. This is another opportunity for to continue our cooperation. The last years we had the opportunity to have a face-to-face meeting in Cairo. Always was very successful. It's pity that now for the COVID story we have to choose this alternative way for a meeting, but I'm sure that also in this way will be a successful symposium. So thank you again for the opportunity of the cooperation between the two societies, and let's go ahead. Thank you.
And now it's my honor to introduce Professor Salah Shilbaya, the organizer of that meeting. And before introducing him to the attendees and the speakers, I would like to thank him for his great effort to make this meeting an activity that is already being started. Professor Salah Shilbaya, you are welcome.
Thank you, Professor Khattab, and thank you for all dear colleagues, and welcome here in Egypt virtually. Actually, this summit will be introduced in 2 waves. This is the first wave, which will be held today and tomorrow, inshallah, and the second wave will be on 6 and 7 August. So this is the agenda of our meeting today. And also I will tell you the summary of the meeting tomorrow. Here is the first speaker, Francesco Cosentino, will talk about current guidelines in management of cardiovascular disease, cardiologist's point of view. And this is the second speaker, Antonio Ciriello. And third speaker is Lelek speaker, and we have our colleague, Professor Nabil Kafraoui, the fourth speaker, and finally we have the symposium of Servier, which will be started by a lecture by Professor Khalifa Abdallah and followed by Aslam Ahmed from South Africa. Now we will start the first lecture, which will be presented by Professor Cosentino. I'm happy to introduce him just after 1 minute. Okay, I am honored to introduce Professor Francesco Cosentino, Chairman of EACD Guidelines on Diabetes, Pre-Diabetes, and Cardiovascular Secretary Treasurer of European Society of Cardiology, EACC. His presentation titled Current Guidelines in the Management of Cardiovascular Disease and Diabetes from a Cardiologist's Point of View. Professor Cosentino, please.
Thank you. Thank you very much. Thank you for the invitation to participate in this webinar on Diabetes Guidelines Implementation Summit. It is a pleasure for me to provide you with a brief synopsis of the 2019 ESC guidelines on diabetes, pre-diabetes, and cardiovascular disease. And first of all, let me acknowledge that these are only my disclosures, the effort to write this guideline was a joint effort made together with 22 colleagues from 16 European countries, and several of these colleagues were appointed by the European Association for the Study of Diabetes. So it was a real joint effort. Now, I would like to say, and I think you all agree with me, that the last 7 years have been the most exciting time in diabetes research ever. And the 2019 guidelines of the European Society of Cardiology reflect such an unprecedented increase in new evidence base available in this field. And if we look at the number of recommendations of this guideline, we have a very high number, under 38 recommendations, based on almost 600 references. And if we compare the number of recommendations of the previous edition of Guidelines on Diabetes, which were published in 2013, in which we have only 84 recommendations. So you can see that there's been an increase in these numbers. And then if we look at in more details to the class of recommendation, you can see that 80% of them are class 1, class 2A recommendations with a level of evidence A and B, which means, according to the classification of the European Society of Cardiology, that these are recommendations are based on data derived from multiple randomized clinical trials or meta-analysis. So this is a tangible proof of expanding available evidence. If we have to say in few words what is new in the 2019 guidelines, here are listed the most novel topics: a new classification of cardiovascular risk in the setting of diabetes. Then, as we all know, there's been an array of different cardiovascular outcome trials testing newer glucose-lowering agents, and these are led to new treatment algorithms, as we will see in a moment. Then we have new recommendations regarding the role of aspirin and the oral anticoagulants, the issue of the duration of dual antiplatelet therapy post-ACS, acute coronary syndrome in diabetes, the choice of revascularization techniques, and these are clear issues which are very closely related to our daily clinical practice as cardiologists. Then we, as you know, we have new and more ambitious lipid targets in relation to the severity of cardiovascular risk and to the use of PCSK9 inhibitor, which is a powerful pharmacological tool enabling us to reach very ambitious lipid target. And then finally, individualized blood pressure targets. Let's now for a moment concentrate on the issue of reclassification of cardiovascular risk in diabetes. We all know that cardiovascular risk is clearly related to the presence of comorbidities, to the presence of other risk factors, and also to the duration of diabetes. So in recognition of this complexity, acknowledging the importance of individualized care, we have adopted a classification with 3 levels of risk, which are depicted here. From bottom up, we have the patient at moderate risk, which are young patients with a duration of diabetes below 10 years without other risk factors. Then we have the high-risk patients, and these are patients with the diabetes with a duration of the disease which is going beyond 10 years. They did not yet develop target organ damage, but they have at least another additional risk factors in combination with diabetes. And then finally, the very high risk category of patients, these are patients with diabetes and established cardiovascular disease, or patients with diabetes who have already other target organ damage, or patients who have on top of diabetes, 3 or more major risk factors, and then a very selective a setting of early onset of patients with type 1 diabetes of long duration, which is more than 20 years. Now, as I say in the beginning, this is one of the most exciting time in the field of diabetes and cardiovascular disease. Since the last edition of the guidelines in 2013, many cardiovascular outcome trials have been performed with newer glucose-lowering agents. And in this very busy table, it is shown all the cardiovascular outcome trials with newer glucose-lowering agents, namely SGLT2 inhibitors, GLP-1 receptor agonists, and DPP-4 inhibitors. I mean, this is a very busy table, almost unreadable, but I would like to point out to you 2 different issues. The first one is that all the trials which are listed on the upper row here, all the trials were designed to detect risk signals. And this was done, as you know, in accordance with the requirement of the FDA and the European Medicine Agency, which required that any new glucose-lowering agent had to prove to be cardiovascular safe. And then another important issue, if we look for a moment at the type of patients which have been recruited in these trials, you can see that almost in most part of these trials, 80 to 100% of the patients had already established atherosclerotic cardiovascular disease, so they were in a setting of secondary prevention. Only more recent trial, such as the DECLARE TIMI58 with SGLT2 inhibitors dapagliflozin or Creedence trial with canagliflozin, you can see that only 40–50% of the patients recruited in those trials had established atherosclerotic cardiovascular disease. So it means that the vast majority had only multiple risk factors, so they were in a sort of primary prevention setting. And the same holds true for the GLP-1 receptor agonist dulaglutide. In the REWIND trial, you can see that almost 70% of the patients did not have established cardiovascular disease, but they had only multiple risk factors. So this is important to take into consideration. Now, let's briefly have a look to the results of these cardiovascular outcome trials according to the class of drugs. Here we have the DPP-4 inhibitors, and we have the 3-point composite MACE, cardiovascular death, non-fatal MI, non-fatal stroke, and you can see that all the trials performed with DPP-4 inhibitor had a neutral effect on the 3-point MACE. On the other hand, when we look at the hospitalization for heart failure, we detected an increase in hospitalization for heart failure in at least 2 of these trials, the SAVO-TIMI53 and the EXAMINE trial. And the SAVO-TIMI53 with saxagliptin had a significant increase. The other one, the EXAMINE, only a trend. So this has to be taken into consideration. Now let's move to the cardiovascular outcome trials with GLP-1 receptor agonist. And you can see that all the cardiovascular outcome trials with this class of drug show an improvement in primary composite endpoint, the 3-point MACE, as is shown in LEADER, in SUSTAIN, HARMONY, Outcomes, REWIND, and PIONEER. And only in LEADER, liraglutide show also a significant reduction in all-cause mortality. Now, if we move to the other class of drugs, the SGLT2 inhibitors, trials such as EMPA-REG, CANVAS, DECLARE, looking at 3-point MACE, had an effect on this 3-point MACE, even more so for hospitalization for heart failure and cardiovascular death. You can see that we have a marked reduction, stunning results in the arms of the trial with the active drugs as compared to the placebo. Only for in EMPA-REG outcomes with empagliflozin, we observe a significant reduction, a 32% reduction in all-cause mortality, which translate into a number needed to treat of 39. So a very impressive results. Now we came to the results of the Creedence trial, which was the first trial having as primary outcome a composite of renal endpoints, end-stage kidney disease, doubling of serum creatinine, or renal or cardiovascular death. And again, you can see that there is a 30% reduction in 4,400 patients which were recruited in this trial with diabetes and chronic kidney disease, an estimated glomerular filtration rate, which was ranging from 30 up to 90, with a follow-up of 2.6, so an hazard ratio of 0.70, so significant reduction. And this trial had as a secondary outcome a composite of cardiovascular death and hospitalization for heart failure, and also in this case we have a significant reduction of this more cardiovascular secondary outcome, so which confirm also for Creedence the results obtained in previous trial. Now, our recommendation, the recommendation of the European Society of Cardiology for glucose-lowering agents, reflects the number of trials that have shown positive results. And as far as the SGLT2 inhibitors, we say that empagliflozin, canagliflozin, or dapagliflozin are recommended in patients with diabetes and established atherosclerotic cardiovascular disease, or patients with diabetes has very high CV risk to reduce cardiovascular events with a class of recommendation 1, level of evidence A, because, as I showed you, the data are derived from multiple randomized clinical trials as depicted here. And then if we, for empagliflozin, we recommend empagliflozin in patients at high CV risk to reduce the risk of death, class 1, level of evidence B, because we have only EMPA-REG outcome which has shown these positive results. Now let's move to the GLP-1 receptor agonist class of glucose-lowering agents. And here we say that liraglutide, semaglutide, or dulaglutide are recommended again in patients with diabetes, established cardiovascular disease, or patients at very high CV risk, according to our classification, to reduce cardiovascular events, class 1, level of evidence A, because we have multiple trials which is demonstrating, supporting such recommendations. And for liraglutide, only liraglutide among the different GLP-1 receptor agonists is recommended to reduce the risk of death, class 1, level of evidence B, because it's only one single randomized clinical trial, the leader, which is supporting these recommendations. Now, with such a wide range of new results, we have to ask ourselves, where do we position metformin today? And metformin should be considered in overweight patients with type 2 diabetes without established cardiovascular disease at moderate cardiovascular risk. This is a class 2A level of evidence C, and this evidence for metformin come, as we know, from the UK PDS trial, which demonstrated that the risk of myocardial infarction is 39% lower with metformin versus conventional therapy in obese patients without cardiovascular disease, because I would like to remind to you that the patient recruited in a UK PDS were patients with newly diagnosed diabetes without established cardiovascular disease. So what about the DPP-4 inhibitor, saxagliptin, based on the results from SAVOR-TIMI 53, is not recommended in patients with diabetes at high risk of developing heart failure, because as I shown you before, this trial demonstrated an increase in hospitalization for heart failure. Now, based on this recommendation, we were motivated to put down some treatment algorithms. And I would like to point out to you two different scenarios. The first one is the scenario of drug-naive patients with type 2 diabetes. Then we have to ask ourselves if this patient has established atherosclerotic cardiovascular disease, or is a patient with high, very high CV risk in terms of target organ damage or multiple risk factors. If we are in this setting, then it is recommended nowadays to start right away with drugs which have proven cardiovascular benefit, such as SGLT2 inhibitors or GLP-1 receptor agonists. And this is evidence coming from the trials I've been briefly presenting. If we are not in this setting of high, very high CV risk, then based on the results of the UKPDS, metformin monotherapy is appropriate as a starting treatment. Then we have the other scenario in which we have patients with diabetes who are already on metformin. And as you know, this is a very common setting. But nowadays, again, if we have in front of us a patient with established atherosclerotic cardiovascular disease, or a patient who has already target organ damage or multiple risk factors, it is important nowadays to add drugs with proven cardiovascular benefit, such as SGLT2 or GLP-1 receptor agonist. If this is not the case, then we can continue metformin monotherapy. And if in case of we need to reach a fair glucose control, then we add other drugs according to the multi-step approach. So basically, the real novelty of this treatment algorithm is that we move from basically a glucocentric approach to a more event-driven type of strategy, because nowadays we have available pharmacological tools which may have an impact on the cardiovascular events of our patient. And again, if we consider the ESC guidelines in comparison to the consensus report by the ADA and the ESD, which was published in 2018, also at that time, the writing committee of that consensus supported that if not glycated hemoglobin is a target, then you can add in patient at high CV risk, add either drugs, SGLT2 or GLP-1 receptor agonist. And because this was based on the fact that all the cardiovascular outcome trials enroll patients with diabetes, established atherosclerotic disease on a background metformin therapy, who were not a target for glycated hemoglobin. But we have to ask ourselves, in order to move from a conservative approach versus a real-world approach, do we really think that these new drugs do not work if glycated hemoglobin level is under control? And then, do patients need really to be on metformin before initiating an SGLT2 or GLP-1 receptor agonist? And another important point, what if a patient with an event is a target for glycated hemoglobin, do not get these cardioprotective drugs, and then experience another event? And then the last point is, what about patients without established cardiovascular disease, but they have only multiple cardiovascular risk? Now, I would like to really share with you the satisfaction that the ADA ESD consensus report move to our position, because in 2018 they were saying that to add these new drugs only if glycated hemoglobin is not a target. Then in the update of their documents, which was published 3 months after our guidelines, they stated that independently of glycated hemoglobin target, it is important to add these new drugs with proven cardiovascular benefits in patients with established cardiovascular disease or patients at very high CV risk. So basically, in moving from the last guidelines published 7 years ago to this guideline, we moved towards a more evidence-based, individualized approach, which is driven by data derived from cardiovascular outcome trials. I think I stop here. Thank you very much for your attention.
Thank you, Professor Cosentino, for your elegant lecture. It is very clear and to the target. And I have only to introduce if there is a question. Ahmed, there is questions or no? Ahmed Yusri. Ahmed Yusri. في questions عندك؟ Ahmed, no questions? Okay. Thank you again, Professor Cosentino.
Thank you.
Now we will proceed to the second lecture.
Okay, I'm really happy to go on with this conjoint meeting between the ESCD and the Egyptian Society of Diabetes and Lipidology. And now I'm presenting the second speaker, Professor Antonio Ceriello, who is the president of the ESCD study group of diabetes and cardiovascular disease. Really, it's a very important conjoint meeting because at the end, we are going to clarify what Professor Ceriello is presenting. Is hyperglycemia per se a cardiovascular risk factor? We had been since years talking about the glucocentric approach of treatment, but now we are talking more of a holistic approach. And this is very important because the glycemia per se is present in type 1 diabetes and even more, but we do not have this cardiovascular risk. We know that diabetes type 2 with the metabolic disturbance, with the multigenetic, with the multiple factor, is the most important thing. I think that Professor Ceriello is going to clarify this point. Is hyperglycemia per se still a cardiovascular risk factor? Professor Ceriello, piacere di averti.
Thank you for the kind introduction. Yes, it's true. We moved from a pure glucocentric approach to a cardiovascular-centric approach, and probably we forgot that also hyperglycemia may have a role as a cardiovascular risk factor. I'm going to show you that the evidence supporting that hyperglycemia must be considered, even today, an important risk factor not only for microvascular complication, meaning retinopathy and nephropathy, neuropathy, but somehow also for cardiovascular disease. These are my conflict of interest. And let's, you anticipated, I think that type 1 diabetes is the model. Sorry to say that a person with the disease can be considered a model for research, but type 1 diabetes, of course, is the model to prove or not that hyperglycemia is a risk factor for cardiovascular disease. Why? Because usually these people are young, and they have only hyperglycemia as a risk factor for a long time. Of course, later they also developed some kind of insulin resistance, hypertension, and so on. But clearly, the key feature is the presence of hyperglycemia. And we learned from the DCCT, particularly from the EDIC study, that even type 1 diabetes, hyperglycemia is a risk factor for the CVD. You saw that in intensive treatment arm in the DCCT, the risk for cardiovascular disease, particularly for the combination of a non-fatal myocardial infarction, stroke, and CVD death was less compared to people treated in conventional way. Let me underline that this pool of outcomes is the same means that has been used in all the CVOT trials. So meaning that in terms of outcome, in the DCCT EDIC was clear that lowering glycemia can reduce MACE. But not only, also we have evidence that after many, many years, even 30 years, a good glycemic control at the beginning of the appearance of the disease, type 1 diabetes, still was playing a key role in conditioning the development of almost all the risk factors, the complication, but particularly also the cardiovascular complication. So the first question is hyperglycemia by itself a risk factor for cardiovascular disease? I believe that the answer is yes, it is. And this was also supported by the evidence of UKPDS. You know, the UKPDS was performed in type 2 diabetes, and also in the UKPDS, we had to prove that after even 10 years of follow-up, the good glycemic control was giving some protection against cardiovascular events. So meaning that also in type 2 diabetes, glycemic control plays a role in reducing the cardiovascular risk. So if you have a look, however, at the UKPDS compared with the other 3 important trials, which were aiming to show that good glycemic control can prevent cardiovascular disease, and they were not only negative, but in the case of the Accord, you remember, there was a really warning because there was an increase of total death. But there is a huge difference in these studies. If you compare the duration of the diabetes in the UKPDS with the duration of the disease in advanced Accord of VADT, you see that in the UKPDS, the control of glycemia started almost at the beginning of the appearance of the diabetes, while this was not the case in the other studies. And probably you remember the concept of metabolic memory, meaning that at the beginning, high glucose can imprint tissues and cells, and this imprinting can last even years and can lead to the complications. And this way, regarding taking in account the concept of metabolic memory, we can explain why the result of UKPDS was so brilliant, showing that reducing hyperglycemia, you can prevent cardiovascular disease, while, for example, in the VADT was not the case. Or in the VADT, intensive control was started after many, many years from the appearance of diabetes. It is reasonable that during these years, the metabolic memory was rising, and so reducing the chance to have any effect of reducing hyperglycemia. But I think that we have another evidence. If A1C is our gold standard, and you know all the studies were focused on showing that reducing A1C, you can estimate the impact on the complication, for example. And there, you know that there is a linear correlation between fasting glycemia and A1C. So if A1C is our gold standard and just is the best measurement for evaluating glycemic control, If a type 1 diabetes has optimal glycemic control, almost a normal A1C for his life or her life, which could be the impact on complications. Ideally 0. If A1C is the gold standard of glycemic control, and the person has a normal A1C for all the life, his or her life, the expectation is that he cannot develop complication, particularly in type 1 diabetes, when only glycemia, hyperglycemia, is the marker. Well, it's not the case. From this registry, it's a very famous registry from Sweden, you see that even in the case that people with type 1 diabetes had in their life a very normal A1C, 6.9%, anyhow, they were exposed to higher risk for complication, including cardiovascular complication. This means that A1C is unable to catch all the problem of hyperglycemia in diabetes. Otherwise, in this case, the impact of a complication should have been 0. And maybe you remember that some years ago, the IDF developed specific guidelines underlining the issue of postprandial hyperglycemia. And now all the guidelines are suggesting that it's the case to control postprandial hyperglycemia, probably not only because maybe it's linked to an increased risk for cardiovascular events, but particularly that if you want to reach the target of A1C, you must reduce postprandial hyperglycemia. So A1C is important, but it's not enough, because the overall glycemic control also includes at least postprandial hyperglycemia. And again, it's not enough. This is a real historical slide I got many years ago from the Mayo Clinic, when the continuous glucose monitoring started to be used. You see here, you have 9 type 1 diabetes with an A1C or a mean A1C of 6.7%, meaning very good A1C. However, at that time, I repeat, it was the beginning of a continuous glucose monitoring, and then the system was applied. This was the result. So good A1C, a drama in terms of glycemic variability during the day. And we have evidence that glycemic variability, not only in type 1, but also in type 2, is an independent risk factor for cardiovascular disease. This is the first key studies published, 20 years ago, from an Italian group based in Verona, showing that the first time the variability in blood glucose can impact on the cardiovascular risk in type 2 diabetes. After this was confirmed after 12 years in a huge number of people, more than 5,000 in Taiwan. So no doubt, but variability of blood glucose is an independent risk factor for cardiovascular disease. And this has been very recently stressed by post-hoc analysis of several clinical trials. You see here, we have evidence coming from the Advance, from the VODE, the ADT, HEMPA-REG, all have Accord, just last month was published, that glucose variability is an independent risk factor for cardiovascular disease in diabetes. But when we speak about the variability of glycemia, usually we believe that only what is going up is important, but it's not the case. Also, because what is going down is very important, in terms that when you have a huge glucose variability, also you have an increased risk of hypoglycemia. And we know that glycemic variability is really related to high risk of hyperglycemia. And hypoglycemia is well known. It's an independent risk factor for cardiovascular disease. It's coming out from many studies, but I would like to underline that it's coming out particularly from HEDER, UKPDS, Advance, Accord, with ADT. So all the studies are showing that hypoglycemia is an independent risk factor. So let me go to the conclusion. In 2005, Alan Charrington was the president of the American Diabetes Association. In 2005, the EDIC study was presented, particularly where was presented the result of the impact of a glycemic control on cardiovascular diseases. So the first study I showed you, it was presented in this meeting. And when Alan Charrington closed the meeting, his message was that the glucose control should be started as early as possible to delay or prevent serious diabetes-related complications. In my opinion, today we have to a little bit change this approach because, okay, we learned that reducing A1C is very important. Also that fasting glucose, to lower fasting glucose is important. To lower postprandial hyperglycemia is important. To avoid glucose variability is also important. And all these should be got avoiding hypoglycemia. I think that, yes, it's a very tough job for physicians because you see here that to avoid the risk related to hyperglycemia, you must be always in a normal range of glycemia, which is honestly a very difficult task and a goal to achieve in the daily management of diabetes. So in my opinion, we can conclude today that to just reward the take-home message that Alan Charrington gave us in 2005, and to an update take-home message is that, first of all, hyperglycemia is a risk factor for cardiovascular disease. Probably is not so important as cholesterol, lipids, blood pressure, but it is a risk factor for cardiovascular disease. And that today, a good glucose control, meaning the control of all kind of hyperglycemias, avoiding hypoglycemia, should be started as early as possible to delay or prevent serious diabetes-related complications. So in other words, the answer is yes, hyperglycemia is still, it should be still considered a risk factor for cardiovascular disease. Thank you very much.
Thank you, Professor Ceriello, for this very interesting talk and really enlightening. We are no more, because at a certain time, it was said diabetologists are out of business because the problem is not hyperglycemia. No, hyperglycemia is still. We cannot exclude the initial result years ago of the UK PDS pointing to the importance of hyperglycemia. And what is very important, you stressed on it, the early treatment of hyperglycemia. And this, I think, is very important. And at the same time, I know and I agree that it's very difficult to reach a proper diabetes control and to avoid very high glucose variability. All over the world, in countries where diabetes is very well treated, a lot of people do not reach neither good fasting, good postprandial, good hemoglobin A1C, and still develop hypoglycemia. So the pentad is so difficult, but we have to do a lot of effort to reach that.
What to say? The evidence is there. You cannot ignore the evidence.
Yes, sure. I don't know if there is questions. Okay, thank you very much, Professor Ceriello, for this enlightening talk. And we hope to meet again soon in vivo and in webinars. Thank you very much.
Ciao.
Bismillah ar-Rahman ar-Rahim. Dear colleagues, ladies and gentlemen, it gives me great pleasure to acknowledge your presence and for the Diabetes Guidelines Implementation Summit entitled From Guidelines to Clinical Practice. I'm very honored to present the next speaker with this meeting, Professor Neboja Lalique. He is a president-elect of the IDF Europe. He is a board member of the ESD study group of diabetes and cardiovascular disease. And his talk will be on diabetes management during COVID-19. We know that persons with diabetes have an increased risk of severe complications, including SARS and multi-organ failure. The question is, how can diabetic persons reduce risk from COVID-19, as well as what about the anxiety and diabetes-related distress during this pandemic? What about self-management and care during this pandemic? And how to achieve good glycemic control during this pandemic, which may help in reducing the risk of infections and severity. Professor Lalique, please start your talk.
Thank you very much. Thank you for, I would like to thank the organizers, both associations and some of my Egyptian colleagues that I know from the MGSD meetings, and also Antonio Ceriello and Professor Costantino for inviting me all together to be present at this meeting and to give this talk, which is a little bit with a different title in comparison to the previous ones. But however, you will see that the question that Professor Ceriello has addressed in the previous talk about the necessity of maintaining the good control for the outcome of the good metabolic control for the outcome of comorbidities, and which are most very frequently due to complications of diabetes, is very important. But let's start it from the beginning. So I have some problems here. I thought it was selected. I clicked, but it doesn't. No. Okay. So in order to tackle this issue, I would like to, I composed my talk of three parts. In the first one, I would remind you about this association between diabetes and COVID-19, which has been recently discovered after the beginning of the epidemic, and that attracted a lot of attention because many things are not known. Even the other part of the story has brutally attracted our attention to the fact that many people, many more people died of diabetes in COVID, and that was very much alarming. In the second part, I would like to put some points regarding treatment of diabetes, how it is adapted during COVID infection. And finally, many associations, including our study group, were very active in providing some recommendations how we should behave in the COVID infection as itself. So let's start from the beginning. Very brief look to the epidemiological data from the very beginning of the epidemics, of the pandemics, has shown that diabetes is somewhere high on the as a comorbidity during COVID epidemics. it appears to be that 1/10 of the patients at least had diabetes, and very similar, as you can see, to the cardiovascular diseases in this very brief and superficial analysis, but based on a number of studies a number of data from 1,500 patients from China and seven studies. Then, it was not just that diabetes was a risk factor. If the people with higher severity of the disease were analyzed with the severe COVID-19 symptoms, it appears to be that there was a significant difference, and that the more severe variant of COVID-19 appeared in people that previously had diabetes, and in some of the studies it was like 4 times or 3 times higher than in when other comorbidities were concerned. So diabetes had a very prominent place. And finally, what was very drastic, the prevalence of non-survivors, as which was another name, of course, of the people that died from COVID, was, as you can see in this dark blue columns, about at least 2 times higher than those than in non-diabetic environment. That definitely put diabetes at a very high agenda, and attracted, at least in this rather short time, because people were busy with COVID itself. So there wasn't many research, and the research is still to follow. But the diabetes was there at the very very high at the agenda. Our Italian colleagues however, had enough strength and effort strength to make an effort to put the data together, and we obtained this dramatic figure that if you taken somehow different angle looking at the COVID and hyperglycemia, you can see that with this green line, that the mortality is 50% higher in those patients than in those ones who did not exhibit hyperglycemia. That was very much worrying, and but going into deep with these data in the same study, the authors could make a distinction between people with diabetes and without hyperglycemia, which meant well controlled, in fact, and people with diabetes and hyperglycemia. And there was this is a green and light green lines, curves, and the difference was significant. So the mortality and the survival, this mortality was greater, the survival was less in the group of diabetic patients with hyperglycemia and with diabetes. That put into the center of our thinking the metabolic control in this particular situation of the COVID infection. So that is what are the experiences from Italy, and practically by the same time. And you can read down at these slides on the right lower bottom that these publications are from May and June of this year. So they were done definitely in a sort of rush together with fighting against COVID. but the similar data coming from China also have shown that poorly controlled diabetic patients had a significantly lower percentage of survival compared to well-controlled. And these authors made a sort of graphic abstract, which for their paper. And this graphic abstract has shown that at the beginning, if you have a well-controlled with blood glucose, which is for them less than 10 millimoles per liter, the survival was very, very, very high. But if the situation goes if the situation gets complicated, if the upper limit goes above 10 millimoles, if we have poorly controlled blood glucose, then we can end up even with 11% of deaths. So that is these are the data that shaped, however, our space for thinking how to treat diabetes, how to get how to implement the blood glucose control. However, it was not only the changes of the level of blood glucose, but these changes were very much associated with the changes of the parameters of so-called cytokine storm. And you can see the data that patients with poorly controlled diabetes had lower lymphocytes and higher neutrophils, but also they had higher levels of cytokines that were recognized as very dangerous mediator of the bad outcome of the whole infection. So through this study, at the significant number of patients, the thing was realized that there is a tight connection between the metabolic control, glucose control mostly, but also that's definitely includes other aspects, and the inflammation that worsens the outcome of the disease. Taking all this into account, even the practicing physicians at the COVID clinics, but also all of us, were in front of the dilemma what to do with the treatment of diabetes as it is designed nowadays, and how to manage this treatment with what kind of drugs should we use, and what are the experiences with that. There are not many experiences until now, but however, a rather large panel of diabetologists gathered around the publication in Lancet Diabetes and Endocrinology, and that went through most frequently used medications in diabetes, and they pointed out some dangerous situation in which we can come with these agents, not precluding that these agents should be withdrawn from the treatment, but however that we should take care of what might be the consequences. Regarding metformin, very widely used agent, it appeared to be that if we are not patient enough, that if we get into dehydration or renal function goes down, that if we do not carefully monitor that, we can run in the first situation into lactic acidosis, which we haven't seen for a while. And if renal function is not monitoring, we can go to the acute kidney injury, and we should adapt the treatment to that. What can be the practical adaptation? At this moment, the good old sick day rules came again, and now adapted to the situation, to the new situation of COVID-19, and IDF Europe changed it and adapted to all this problems and manifestations that we can come across, especially in the situation of rather isolated diabetic patient treated themselves or being treated remotely. So this might help in this particular situation. SGLT2 inhibitors, we have heard how many positive effects they have, but the panel has recorded some precautions, and these precautions are, again, like metformin, risk of dehydration and diabetic ketoacidosis during illness, and the problems with impaired renal function if the acute injury comes around. But also it has been found that we should avoid these type of agents and initiating them during respiratory illness. And in general, there was a fear, never proven, in fact, that SGLT2 inhibitors are stimulating the expression of ACE2 inhibitors, ACE2 receptor, and doing potential damage, but that has not been proven in a human situation. GLP-1 receptor agonists are also, of course, they are also, as the previous agents, very useful in the treatment and the prevention of cardiovascular outcomes. But however, again, it's dehydration that is around, and that can result in the necessity of withdrawing these drugs. The insulin DPP-4 inhibitors in this particular situations were first accused that they might bring a lot of harm, because DPP-4 is a receptor, but for coronavirus, but not for SARS coronavirus 2, which is the one that is causing the epidemics now, but for MERS coronavirus. And it appeared to be that these drugs are generally well tolerated, and the treatment can be continued, of course, if the catabolic state is not very much pronounced. Finally, insulin should not be stopped, but the regular adjustment should be very tight, because in order to avoid possible complications, hypoglycemia and so on, that might appear in the present situation. This was those were the opinions of the panel. The other group of authors, with David Matthews, did practically the same thing and published it practically at the same time in May of this year, and had practically the same opinion. You can follow this third column, suggestion for practice, in which there are a lot of stops, but in very defined situations. But what they suggested very openly and much more than the previous group is that insulin is a drug of choice in critically ill patients, and that in that case it should be widely used. In the otherwise experimental review done by Dan Drucker, in which evaluated different receptors and their interactions, and the interactions of anti-diabetes drugs with these receptors, there was a suggestion that insulin is the glucose-lowering therapy of choice for acute coronavirus-related illness in hospital, which is pretty much similar to the previous statement of the David Matthews group on the use of insulin in critically ill patients. Taking all this together, we are coming to recommendations. There are not too many of them, but they, because the time was generally very short to have enough evidences, but some of the groups had the courage to go into it. And the previously mentioned panel did the consensus statement more than recommendation, in which it is interesting to see that they somehow distinguished outpatients care. So the people that are not, and the need for prevention of infection in diabetes, and that they emphasized also sensitization of patients with diabetes for the importance of optimal metabolic control, and the utilization of telemedicine and connected health models. It means digital health in order to avoid this potential isolation in which those people can come in. Once they are hospitalized, this group suggests intravenous use of insulin therapy in a number of situations, especially with ARDS or the hyperinflammation, and as really the drug of choice in diabetic patients. Finally, they are following practically the same therapeutic aims as in the treatment of diabetes. In the UK, continuing the same line, they developed a very precise guidelines for the use of insulin. Our group, and I hope that Antonio won't mind that I present this, which he in fact did, and wanted to do sort of comprehensive recommendations for decreasing cardiovascular risk in people with diabetes in the COVID era, in which we should take care at the beginning on admission, and not only on blood glucose, but also on all other risk factors, the more than one risk factors. And then we, if we go on, further on, we should take care of all this list of the diseases. Finally, at the lower right end and square, it is that if the patient ends up in the ICU, we should stop all OADs and subcutaneous insulin, switch to intravenous insulin, and take care about blood pressure with continuation of ACE ARBs, and take care of glucose variability with CGM. Finally, this is my last slide. If there is something new in this situation, the emerging evidence suggests that association between diabetes and poor glucose control is very tightly related to the worse outcomes of COVID-19. And so there is an important challenges of glycemic control during acute illness. But also there is a changing role of the diabetologist that should now concentrate and focus the prevention, which means keep people out of hospital by a lot of means that we have, and we don't have too much of them because the situation is difficult. But that we should concentrate on doing a lot of them improving metabolic control, which prevents then the burden during the possible complication if the infection does happen. Thank you very much.
Thank you very much, Professor Lilac, for a very elegant and comprehensive presentation. Hello. Thank you very much, Professor Lilac, for a very elegant presentation and comprehensive one, suggesting that the importance of good glycemic control and the use of insulin whenever is appropriate, and intravenous insulin infusion in cases with severe comorbidities due to this COVID-19 infection. Thank you very much. Do you have any questions? لغاية دلوقتي مفيش أسئلة خالص. Okay, then I think that everyone is satisfied. Thank you very much, Professor Lilak, again.
Thanks to you. Thank you.
Thank you. Thank you.
And now we are shifting to the next lecture. I'm very happy to introduce my friend and colleague, Professor Nabil Kafraoui, Professor of Internal Medicine and Diabetes, Montefiore University, Egypt. He will talk about hypertriglyceridemia. Hypertriglyceridemia in diabetes as a cardiovascular risk factor. Dr. Nabil, please.
First, I want to introduce my thanks for the organizing committee and Professor Salah Shilbaya for this kind effort. And I want to thank all professors. My topic today is the hypertriglyceridemia in diabetes as a cardiovascular risk factor. As we all know, the dyslipidemia is defined as an abnormal pattern of lipids in the blood, the triglycerides, cholesterol, and phospholipids. And this mostly occur in the developed countries due to the Western type of diet lifestyle and increase the prevalence of obesity, which is associated with the insulin resistance. This is the atherogenic diabetic dyslipidemia that constitutes of elevation of the triglyceride more than 150 milligram per deciliter and LDL more than 100 milligram per deciliter, or the pattern of the LDL, which is the pattern B, or the increased small dense LDL. Beside the low HDL, less than 40 for males and less than 50 for females. There is a hypertriglyceridemia has a direct relation or a linear relation with the insulin resistance, and this is the meta-analysis that stated that the hypertriglyceridemia is associated with the doubling of the serum insulin with the hyperinsulinemia, and there is an intimate linear relation, direct relation between the hypertriglyceridemia and the hyperinsulinemia. The most common causes of the hypertriglyceridemia are of secondary origin, for example, the positive energy balance and the increase in the carbohydrate intake, diabetes mellitus, hypothyroidism, nephrotic syndrome, and some medications as the antiviral medication for HIV, thiazide diuretic, glucocorticoids, the oral estrogen, and others. This is the secondary causes of hypertriglyceridemia. While the genetic causes of hypertriglyceridemia, the most common cause of the genetic type of hypertriglyceridemia, mainly familial combined hyperlipidemia, variable increase of the triglyceride and cholesterol, genetic defects in lipoprotein metabolism, increased ApoB, increased coronary artery disease risk, and the familial hypertriglyceridemia. However, the Mendelian randomization studies strongly suggest that the genetically determined hypertriglyceridemia can cause the atherosclerosis, but the genetic counseling or genetic testing for this genetic type of the hypertriglyceridemia is rarely used in the clinical practice. This is some clinical presentation of the hypertriglyceridemia. For example, the eruptive cutaneous xanthomas, lipemic plasma with the lipemic retinalis, palmar crease xanthomas, and tuberous xanthomas. This is some clinical presentation of the hypertriglyceridemia. There is an increased risk of the cardiovascular disease with the hypertriglyceridemia, and this is due to other serious consequences of the hypertriglyceridemia, as low level of HDL, presence of the pattern B or the small dense LDL particles, the presence of the atherogenic triglyceride-rich lipoprotein remnants, insulin resistance, increase in the coagulability and viscosity, and pro-inflammatory status or the increase in the inflammatory milieu of the patient. These are the consequences of the hypertriglyceridemia that lead to the atherogenicity or increase in the cardiovascular risk. It was found that the LDL pattern have two main patterns, pattern A with large molecule and pattern B with small dense molecule. And it was found that the fasting triglyceride, when the fasting triglyceride is less than 100 milligram per deciliter, most of the population has predominant type pattern A LDL with large molecules, while if the fasting is more than 250 milligram, mostly these patients have the pattern B of the small dense LDL, which carry more atherogenic as regards the cardiovascular risk and cardiovascular morbidity. So we must reduce the hypertriglyceridemia less than 200 milligram per deciliter to avoid or to reduce the atherosclerosis. These are some mechanisms for the atherogenicity of the causes of the atherogenicity of the hypertriglyceridemia. The triglyceride-rich lipoproteins or triglyceride-remnant lipoproteins acting by the lipoprotein lipase, leading to the triglyceride-rich lipoprotein remnant that contains the high amount of the small dense LDL. Small dense glycated and oxidized LDL has a high affinity to penetrate the endothelium, to pass to the subendothelial region, at which it is engulfed by the macrophages to form the foam cells. That is the main cornerstone for the formation of the plaque. This condition is associated with several atherogenic actions, as the accumulation of adhesion molecules, inflammation, oxidative stress, thrombosis, coagulation, beside increase in the endothelial permeability and endothelial dysfunction. This is one mechanism of the atherogenicity of the hypertriglyceridemia. Another mechanism is promoting the arterial wall inflammation through the accumulation of the adhesion molecules. Other non-lipid factors may drive the cardiovascular risk, as the increase in the coagulation factor, impairment of the fibrinolysis, pro-inflammatory factors, and endothelial dysfunction. All these factors contribute to the atherogenicity due to the hypertriglyceridemia. This hypertriglyceridemia is considered to be as an independent cardiovascular risk factor from this meta-analysis of about 17 studies, more than 55,000 patients. It was found that for every increase in the triglyceride level of 89 milligram per deciliter, this is associated by increase in the cardiovascular risk in male by 32% and in female by 76%. And this is another meta-analysis of 29 studies, stated that the patients in high tertile of the serum triglyceride had 72% higher risk of the cardiovascular disease than those in the lowest tertile. And the hazard ratio here is 1.7. This means that there is increased cardiovascular risk by about 72%, whatever the subgroups, either according to the duration of the follow-up, the sex, the fasting state, or the adjustment of the HDL, whatever these subgroups, there is increased risk of the cardiovascular disease and the highest tertile hypertriglyceridemia. So there's the one fact that the hypertriglyceridemia is associated definitely with the atherogenesis. Then the question, if we treat the hypertriglyceridemia, this will revert this cardiovascular risk or prevent this atherogenicity? Yes, this is by lowering triglyceride PPAR alpha agonist can reduce the macro and microvascular complication of the type 2 diabetes. And this is another meta-analysis of about 18 trials, including about 45,000 patients, the reduction of the hypertriglyceridemia by PPAR alpha agonist associated with the significant decrease of the major cardiovascular event, coronary artery event, albuminuria, revascularization, and retinopathy in a significant statistical way. So let's look how triglyceride reduction benefits in outcome. Is it fact or myth? This is the cardiovascular benefit of the PPAR alpha agonist. These are two studies, VAHIT and BIP study on coronary artery disease patient. The VAHIT trial, they randomized the patient to the gemfibrozil versus the placebo for 5 years. The primary endpoint was non-fatal MI and coronary heart disease death. This is associated with significant improvement of the cardiovascular or the primary endpoint, the non-fatal MI and coronary heart disease death by 22% reduction, which is significant. And BIP using also the bezafibrate versus placebo, and about 3,000 coronary artery disease patients were randomized in this study. The primary endpoint was fatal and non-fatal MI, sudden death for 6 years. It shows also significant decrease of the primary endpoint in favor of the PPAR alpha agonist. While in the field trial in the 2005, this field trial include about 9,800 patients aged from 50 to 75 years, type 2 diabetic, and they have no clear indication for cholesterol-lowering therapy. They randomized this patient to fenofibrate 200 milligram versus the placebo. The primary endpoint was the composite coronary artery disease death, non-fatal MI, and the follow-up for 5 years. The results of this field trial, the PPAR alpha agonist fenofibrate showed no clear benefit in the primary endpoint after 5 years. There is no benefit, there is no significant difference between PPAR alpha and the placebo. But when they come to do the sub-analysis in subgroup of patients, type 2 diabetic patients with high triglyceride and low HDL, or what we call the atherogenic diabetic dyslipidemia, they found significant results. About 23% reduction, significant reduction in the subgroup of patients who have the triglyceride more than 204 milligram, and 27% reduction, significant reduction in favor of the fenofibrate when they include the patients with high hypertriglyceridemia more than 204 milligram and low HDL less than 34 milligram per deciliter. This is the conclusion of the field. Sub-analysis for this atherogenic or the atherogenic diabetic dyslipidemic patient, they get the benefit from the fenofibrate. Also, the ACCORD trial, this include about 5,500 patients, type 2 diabetic patients. All the patients are on the simvastatin, and they randomize the patient to addition of the fenofibrate 160 milligram versus the placebo. The primary endpoint was the first occurrence of non-fatal MI, non-fatal stroke or death from the cardiovascular causes, and this is a mean follow-up period of 4.7 years. Again, there is no significant difference between the fenofibrate and the placebo if they took all the population. But in this subpopulation, again, in the subpopulation with hypertriglyceridemia and low HDL, there is a significant difference with risk reduction of about 31% in the favor of the fenofibrate versus the placebo. The limitation of the field trial ACCORD, in the field, more of the patients in placebo, 17%, than in the PPAR alpha agonist, 8% only. Received the non-study lipid-lowering agent, which is the statin. This is the one limitation for the field study. While in the ACCORD study, the patient received simvastatin from the day 1 to the end of the trial. This are considered to be the one of the limitations from the field and the ACCORD trial. But the conclusion are very clear that the group of patients who gain benefit from the fenofibrate is the subgroup of patients who have hypertriglyceridemia and low HDL. This is another meta-analysis of 5 landmark studies using PPAR agonists on about 4,700 patients. This trials, ACCORD trial, field, BIP, HHS, and VAHIT study, all these also do the sub-analysis for the patient with the hypertriglyceridemia and low HDL. They found that there is 35% reduction of the cardiovascular risk in favor of the addition of the fenofibrate. while this effect is not present in the all population or all the patients who have the triglyceride less than 204 and the HDL more than 34 milligram per deciliter. This is scheduled for the different studies in the last 30 years, but I want here to highlight the era of the add-on statin therapy. From, for example, the GIS study where they add the ethyl EPA on top of the simvastatin, they found that the primary endpoint was significant results in favor of the addition of the ethyl EPA. And also when they took the subgroup of the atherogenic diabetic dyslipidemic of high triglyceride and low HDL, also there is a significant difference in favor of the addition of the ethyl EPA on top of the simvastatin and pravastatin. So what is the ethyl EPA and what is the icosapent ethyl EPA, and what is the difference between this and the omega-3 capsule? First, omega-3 fatty acids are essential fatty acids and the class of nutrient needed for our body to function normally, and it cannot be produced by the body and should be supplied from the diet, and they are present in three forms: the alpha-linoleic acid, the icosapentaoic acid, and the docosahexaenoic acid. These are the three forms of the omega-3. Their functions in the body summarize in the relaxation and contraction of the muscles, blood clotting, digestion, fertility, cell division, growth, movement of the calcium in and out the cell. These are the main functions of the omega-3 fatty acids. This is marine trial on the omega-3 or the EPA or icosapent ethyl, published in the American Journal of Cardiology 2011. In the patients with very high triglyceride, more than 500 milligram per deciliter, they used the EPA 4 grams alone, 2 grams, 4 grams with the statin, and 2 grams with the statin. They found that the EPA 4 grams on top of the statin therapy is associated with decrease of the hypertriglyceridemia by more than 60% or even 65% reduction. While if the EPA is given 4 grams alone without statin, this reduction may be about 35% reduction of the hypertriglyceridemia. Another trial, which is the ANCHOR trial, again published in the American Journal of Cardiology 2012. This is trial 12 weeks in the patients with mixed dyslipidemia, and on top the statin they add the EPA, and this associated with 22% significant results with the decrease of the hypertriglyceridemia, 14% non-HDL reduction, LDL reduction by 8%, and ApoB by 9%. So the European Society of Cardiology at 2019 stated that statin treatment is recommended as the first line and the first drug of choice for reducing the cardiovascular risk in patients with hypertriglyceridemia. So the statin is still the cornerstone for the treatment of risk in the hypertriglyceridemic patient, class 1B. And in high patients, in high-risky patients with hypertriglyceridemia, from 135 milligram to 500 milligram, despite the statin therapy, the addition of the icosapent ethyl by 4 grams per day, 2 grams twice daily, should be considered in combination of the statin, which is the class 2A. On the other hand, at LDL goal with the triglyceride is more than 200, fenofibrate may be considered in combination with the statin. And in high-risk patients for the primary prevention, at which the patient reaches to the target LDL, but still the hypertriglyceridemia is present, fenofibrate or bezafibrate may be considered class 2B. So there is a difference between the icosapent ethyl and the fenofibrate. Icosapent ethyl should be used in addition to the statin, while the fenofibrate may be used in this comparison. This is class 2A, and this is the class 2B. What about the American Diabetes Association in 2020? They stated that the fasting hypertriglyceridemia more than 500 milligram we should exclude first the secondary causes, and we tackle the hypertriglyceridemia by medical treatment to avoid pancreatitis, and we should intensify the lifestyle modification and the other treatment of the other secondary causes. In patients with atherosclerotic cardiovascular disease or other cardiovascular risk factors and on statin therapy with controlled LDL cholesterol but still elevated triglyceride, the addition of the icosapent-ethyl can be considered to reduce the cardiovascular risk, and this is class A. Statin plus fibrate combination therapy has not been shown to improve the atherosclerotic cardiovascular disease outcome and generally not recommended. The statin plus niacin are contraindicated because of the high level of the side effect, for example, increase in the stroke and others. Mr. Chairman, dear professors, dear colleague, to conclude, the atherogenic diabetic dyslipidemia characterized by increased LDL cholesterol or the small dense LDL, hypertriglyceridemia, and low HDL. For patients with fasting triglyceride levels more than 500 milligram, evaluate first the secondary causes of hypertriglyceridemia and consider medical therapy to reduce the risk of pancreatitis, class C. Statin therapy is still the main drug of choice to decrease the cardiovascular risk in high-risky patients with hypertriglyceridemia. In patients with atherosclerotic cardiovascular disease or other cardiovascular risk factor already on a statin and controlled LDL cholesterol but still elevated hypertriglyceridemia from 135 to 500, for example, the addition of the icosapent-ethyl should be considered to reduce the cardiovascular risk class 2A by the European Society of Cardiology and by the American Diabetes Association. Finally, the statin plus fibrate combination therapy has not been shown to improve the atherosclerotic cardiovascular outcome and is generally not recommended, class A, by the American Diabetes Association. However, this combination was of significant value to decrease the cardiovascular event and may be considered in subgroup of patients with atherogenic diabetic dyslipidemia in the form of hypertriglyceridemia, low HDL, and this is class 2B. And thank you.
دكتور نبيل، نشكر الدكتور نبيل على very fruitful presentation. موضوع الهايبرترايجليسيرايديميا موضوع يعني شائك، كان زمان بيقولوا انه مش مهم، دلوقتي اصبح فيه زي ما ورانا الدكتور نبيل كذا consideration وكذا evidence على ان الهايبرترايجليسيرايديميا after excluding the secondary cause should be lowered by medications like the omega preparations. والhypertriglyceridemia is one of the atherogenic dyslipidemias اللي بتعتبر دلوقتي one of the cardiovascular risk factor for the type 2 diabetic patient. Considering triglycerides, high triglycerides after using the statin is of great importance in reducing the cardiovascular risk in type 2 patients. بنشكر الدكتور نبيل، والحقيقه نظرا لضيق الوقت فاحنا هنأجل الاسئله دلوقتي ونintroduce النكست سبيكر. شكرا دكتور نبيل.
Once again يعني بنكمل الميتنج of today. And I want to thank again Professor Salah and the board of the Egyptian Society of Diabetes and Lipidology, as well as the ASD, for this very important meeting. Now we will start some survey symposium. It will be divided into two important lectures. The first one will be delivered by Professor Khalifa Abdallah, Professor of Internal Medicine and Diabetes, Alexandria University. He will be talking on a very important point, hypertension and the need for new antihypertensive medications. All of us are aware that guidelines in hypertension are evolving like the guidelines in diabetes. And you may have heard that recently, couple of days ago, just a few days ago, the International Society of Hypertension has published its recent guidelines. There are new classifications, new definitions of hypertension, new approaches for treatment. Professor Khalifa Abdullah will be talking now to try to answer a very important question. Do we need at present a new antihypertensive drug? Professor Khalifa, you are welcome.
Thank you, Professor Khattab. Good evening, everyone. Actually, within the next 20 minutes, I'm going to talk about the combination therapy in antihypertensive therapy. I will start by showing the data from Ministry of Health project 100 مليون صحة in Egypt. It has been shown that about 21.5% of the Egyptian adults are hypertensive. 1/5 of our adult population have hypertension. But what is really astonishing is that 88% of the hypertensive Egyptians are unaware that they have hypertension. And again, more astonishing, that those who know are unaware of hypertension, they are not receiving proper treatment. And that's why 92% of hypertensive Egyptians receiving treatment are uncontrolled. This will left us with what? Just a very small fraction of the hypertensive Egyptian diabetic reaching the target. This is really astonishing, really depressing for us, because we know that hypertension is definitely a major cardiovascular risk factor. This data from outside Egypt, a multinational study saying that about 60% of patients who are taking treatment for hypertension, even with dual therapy, they don't reach target. That's why we need to change the strategy. What is really important, because sometimes the patient takes suboptimal dose of antihypertensive treatment, you are prescribing 2 or 3 drugs for them and just taking one of them, saying, oh, I'm just taking the antihypertensive treatment. This study shows that untreated, uncontrolled hypertension has a very bad prognosis as not treating hypertension at all. So please be proactive, put your target with your patient, and please advance your therapy till you reach the goal. Don't forget that the major cause of death all over the world, and nearly 46% of the total mortality in Egypt is due to cardiovascular disease. Hypertension, one of the major risk factors for cardiovascular morbidity and mortality, and should be targeted efficiently. So the title was, do we need new treatment for hypertension? We don't have new classes of drugs since many years now, but actually we have potent drugs in the market, but we don't use it properly. So we need new strategy for management of hypertension. We need more awareness. We need more patient education regarding the importance of hypertension control. And we should educate our patient that controlled hypertension doesn't mean that you don't have headache, because our patient says, I'm controlled, I don't have headache. We have to educate them that they have to measure their blood pressure frequently and to achieve a certain target for each individual. We have to educate our patient about the importance of patient adherence to treatment. And we use drugs that can control blood pressure for 24 hours. We should encourage single pill combination therapy because it increases the adherence and promote effective control of blood pressure, and to choose drugs that can achieve our goal. If you look to the guidelines of the European Society of Cardiology, European Society of Hypertension, last guidelines categorize hypertension into 4 grades. Grade high normal is considered a grade and should be targeted if the patient have comorbidities like diabetes or so. Grade 1 hypertension up to 159 systolic and 99 diastolic, grade 2 up to below 180 systolic and 110 diastolic, and above that is grade 3. You can see here that from grade 1, 2, and 3, you should encourage immediate drug treatment, except in low-risk patient with grade 1, you can allow for 3 to 6 months lifestyle modification. However, if a patient with grade 1 hypertension and at high risk for cardiovascular disease, diabetic nephropathy, strong family history, whatever, you have to start even immediate treatment. What is important here, they said that it's much better and recommended to start even from grade 1 hypertension to use combination therapy, even low dose combined therapy, because it achieves better and sustained blood pressure control, and actually you are targeting hypertension from different pathophysiological mechanisms. So the strategy of fixed dose combination is encouraged nowadays, and the patient is taking just one tablet. Taking the two drugs together, usually he will not forget to take it. But if you give two separate tablets, he may take one and forget the other. So please start by fixed dose combination, even with the small doses of the two classes. Then, again, they advise you to use the most popular 4 classes of drugs that have evidence from randomized control trial that they are not only effective in controlling blood pressure, but also in preventing cardiovascular outcome. And this is the main objective of management of hypertension, to decrease morbidity and mortality. So the evidence is with 4 classes: ACE inhibitors, ARBs, calcium channel blockers, and diuretics. So you have to choose a combination therapy of 2 of them. If you don't achieve your goal, you have to add a third drug within the 4 classes. Of course, you can't combine ACE with ARB. So usually in 3 drugs, you are going to use ACE or ARB plus calcium channel blocker plus a diuretic. If you give the 3 drugs with full dose and you don't reach your target, this is called resistant hypertension after excluding some errors in measurements and so on. Then you can add spironolactone and so on. Beta blockers is considered only if there is compelling indication like post-myocardial infarction, heart failure, angina, and so on. Even the ADA standard of care for controlling blood pressure in diabetes again said you have to use one of the 4 drugs: ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, and thiazide-like diuretics. But the difference here, in stage 1 hypertension, you can use monotherapy. But from grade 2 above, you have to start by dual therapy, combination of 2 of the 4 classes as the European guidelines. If you don't reach the goal, you have to add the third drug. The choice here depends on the presence or absence of nephropathy. If there is nephropathy, it's of course advisable to start by ACE or ARB in the combination. Well, so we will come up at the end. If you can't reach your goal with dual therapy, you are going to give the patient 3 drugs: a RAS inhibitor, whether ACE or ARB, a diuretic, and a calcium channel blocker. Which one? Which individual drugs in these? Actually, most of the guidelines says it's a class. Give ACE or ARB, give a diuretic, and a calcium channel blocker. However, if you look to the data, we are going to see some favorable effects of some molecules within the class. I'm today talking in survey symposiums, so I'm going to concentrate on perindopril and dipamide within the class of ACE inhibitors and diuretic. If you look here, while several RAS inhibition successfully reduced either primary or secondary nephropathy, yet only perindopril-based treatment reduces both primary and secondary nephropathy plus mortality, as you can see here. And again, in another trial, prendoprel and dipamide fixed dose combination have shown to reduce secondary stroke in patients with previous stroke. However, this was not achieved, for example, in telmisartan trial in the PROFESS trial. So here we have additional benefit of prevention of secondary stroke. If you look to the guidelines, again, to the text of the 2019 European Society of Cardiology guidelines on diabetes, pre-diabetes, and cardiovascular disease, it is written here within the text in the advanced. They use the advanced trial as a landmark trial. In the advanced trial, the combination of prendoprel and indapamide reduces mortality. And this is very, very important to use a drug, not only controlling blood pressure, but decreasing mortality, a very hard endpoint. Again, in the text of the ADA 2019 guidelines, it is written again, a single pill fixed dose combination of prendoprel and indapamide showed a significant reduction in the risk of primary composite endpoint in advanced, again, trial. So we have a lot of evidence regarding the fixed dose combination of prendoprel and indapamide regarding the decreasing cardiovascular outcome. If you look at the advanced endpoints in the advanced trial, you can see that this fixed dose combination of prendoprel and indapamide significantly reduced all endpoints, primary endpoints, total coronary events, total renal events, cardiovascular death, and total mortality. All endpoints was reduced significantly. And in this review article, a review of renal, cardiovascular, and mortality endpoints in antihypertensive trials in diabetic patient, it is written the only treatment providing primary and secondary prevention of renal events together with significant benefits in terms of all-cause and cardiovascular mortality is the prendoprel indapamide combination in the advanced trial. So, if you use prendoprel indapamide and you don't reach the target, and according to the guideline, you have to add calcium channel blocker. Which one? Of course, amlodipine, as the vast majority of the trial depends on amlodipine in the treatment arm of calcium channel blocker. And it has been shown that it's a very effective molecule and very effective in reducing cardiovascular events, especially stroke, in most of the trial. So, if we use the three drugs together, prendoprel, indapamide, and amlodipine, this is the triple combination. I'm going to talk about it today. So, do we have evidence from trials with these three drugs combined together? Actually, yes. We have the advanced calcium channel blocker trial. It's a part of the advanced trial. You can remember that advanced trial, they registered 12,000 patients, randomized nearly 11,000, adding prendoprel and indapamide fixed dose combination on top of treatment the patient is taking, usual treatment. So in this case, there were about 3,400 patients in the advanced trial were taking already calcium channel blocker. And they divided the groups into those placebo plus calcium channel blocker plus indapamide, prendoprel plus calcium channel blocker. So you are comparing triple therapy here with prendoprel, indapamide, calcium channel blocker versus calcium channel blocker with other antihypertensive treatment. And in this trial, it has been shown that this triple combination decreases cardiovascular mortality by 24% and total mortality by 28%. If you compare this figure, significant reduction in mortality with other trials, you can see from the slide in front of you that this is unattained by any other combination in most of the trials. So it's a very potent, a very good triple combination you can use in antihypertensive treatment. Actually, whether you have grade 1, grade 2, grade 3 hypertension, receiving the triple combination, triplicsan, 3 drugs together in a single pill, by the way, reduces the systolic and diastolic blood pressure significantly, up to 53 millimeters mercury in the systolic and 25 millimeter mercury in diastolic blood pressure in patients with grade 3 hypertension. And in this trial, patient uncontrolled on dual therapy arm that amlodipine shifted to triplicsan. The blood pressure was significantly reduced and reaching the target. And in another combination arm plus diuretic hydrochlorothiazide, and the patient with the dual therapy do not reach the target. Replacing them with triplicsan, the triple therapy, the blood pressure reduces significantly and reaches the target. Don't forget the 3 components of the triple therapy, perindopril, amlodipine, and indapamide. All of them has a 24-hour duration of action. So you are using triple combination of 3 potent drugs that can control blood pressure during the 24 hours as has been shown in this figure. What about the side effects? Actually, very, very minimal side effects. As you see, cough is 0.8%, edema 0.2%, hypotension 0.1%. So within 4 months
بريندوبريل اللي هو الكوفرسيل والانديبامايد اللي هو الناتريلكس والاملوديبين اللي هو النورفاس.
Okay. So this is my last slide. Using triplicsan, the best of 3 classes of antihypertensive drug will be available soon with different concentration, and I hope it will help us to reach our goal. And thank you very much for your attention.
ايوه يا احمد. Thank you, Professor Khalifa, for your very elegant presentation talking about a novel combination of 3 important antihypertensive drugs. Professor Khalifa highlighted the importance of early combination therapy in all recent guidelines. European Society of Hypertension 2018, International Society of Hypertension 2020, and the ADA 2020, all of them highlighted the early combination therapy or fixed combination therapy in hypertension, even in step 1 hypertension. Professor Khalifa also gave an important evidence about the 3 pill combination, the combination containing Natrilex, indapamide, coversil, perindopril, and amlodipine in the same pill, and highlighted a very important fact. A single pill containing 3 important antihypertensive drugs, every one of them has the strongest evidence in its class. And reminded us, Professor Khalifa, that in the advanced hypertension arm, there were almost 3,400 patients who were enrolled on the 3 pill combination, having amlodipine, perindopril, and indapamide, and told us clearly that this combination of 3 antihypertensive drugs led to 24% reduction in cardiovascular mortality and 28% reduction in total mortality, highlighting the importance of early combination therapy, early combination with 2 drugs. And tonight he told us clearly that combination of 3 antihypertensive drugs, perindopril, indapamide, and amlodipine in the same pill, is an advanced step forward in antihypertensive therapy. Thank you, Professor Khalifa, for your illustration. And now we shift to the next part of Survey Symposium. اسمحوا لي حضراتكم on behalf of the board of the Egyptian Society of Diabetes and Lipidology to welcome our guest and friend Aslam Hamoud, in the next part of the meeting, which will be moderated by Professor Yahya Ghanem. Thank you all.
Good evening. Excuse me, I don't know whether it's a good evening or a good night. But first of all, I would like to thank our guest speakers, either from the EASD or from my friend from South Africa. But let me also thank the group which I belong to, the Egyptian Group of Study of Diabetes and Lipidology. And allow me to welcome my dear friend, Aslam Hamoud. Aslam Hamoud is a fellow of the Royal College of Physicians and Endocrinology, and he's based in South Africa. Aslam is the past chair of the Endocrine and Diabetes Society in South Africa, and he has been the chief editor for the South African Diabetes Guidelines 2010. Dr. Hamoud has been involved in principal and lead the South African investigators in many trials, including cardiovascular outcome trials, around 40 articles. He also is a lecturer, regular lecturer in and internationally. We know that sulfonylurea is one of the cornerstones in the treatment of type 2 diabetes. I will ask my friend, which we met lastly in Munich, in an advisory board, Aslam Hamoud, to talk about the position of sulfonylurea in guidelines, which patient and which sulfonylurea. Aslam, have a good time. Thank you very much.
Thank you very much, and thanks for that very kind introduction, and thank you once again for having me join you. It's been a magnificent meeting so far. So for the next 20 minutes or so, I'm going to talk to you about the positioning of sulfonylureas in guidelines. These are my disclosures as they relate to this presentation. And this is a nice quote, whether you're a private detective or whether you're a physician, I think it applies equally. Follow the evidence wherever it may lead you, and question everything. So in terms of the guidelines and where they place sulfonylureas, so if we start with a global guideline, the WHO positions sulfonylurea as a preferred second-line agent, and they prefer gliclazide as the second-line agent. And they make the point that the absolute risk of hypoglycemia with this particular drug is very low. And if you look at the United Kingdom, they have the NICE guideline and the Scottish guidelines, and they both position sulfonylurea as a preferred second-line agent, either with a DPP-4 or a pioglitazone. They only recommend an SGLT2 inhibitor in the absence of cardiovascular disease, only recommend an SGLT2 where sulfonylurea is contraindicated, and as a second-line agent, the GLP-1 is not recommended. They don't believe that the cost justifies its positioning as a second-line agent, again, in the absence of cardiovascular disease. And if you look at, for the rest of the world, from Canada to Australia to South Africa to South Asia, they all have a similar take on the positioning of sulfonylureas. In the absence of cardiovascular disease, a sulfonylurea is one of the preferred agents to be used second line after metformin. And all of these guidelines prefer gliclazide modified release as a preferred sulfonylurea because of the lower risk of hypoglycemia, the lower risk of cardiovascular events, and the lower risk of overall mortality. Now, if we look at the most popular guidelines, of course, have a North American influence. And these are the ADA-EASD guideline and the American Association of Clinical Endocrinologists. And the important thing about these two guidelines is that, of course, in North America, they do not have access to gliclazide modified release. And in these guidelines, they reserve the sulfonylurea really only for the very poor. So you will all be familiar with this ADA-EASD document. And I've highlighted in light green the positioning of sulfonylureas in the guideline. And as you can see, you have to look quite low to find the positioning of sulfonylurea for the majority of your patients. So let's just take this one by one. So for patients with established atherosclerotic cardiovascular disease or heart failure or chronic kidney disease, the sulfonylurea is the last choice after DPP-4, after basal insulin, after TZD. And the implication here is that the sulfonylurea has a worse cardiovascular safety and worse renal safety than these classes, than a DPP-4 or TZD or an insulin. And if you look at patients without established cardiovascular disease, then they make the point that if there's a compelling need to minimize hypoglycemia, then of course the sulfonylurea should be at the bottom, as with the insulin, and I think nobody will disagree with that. So I give that a thumbs up. But the problem is that they do not define this compelling need to minimize hypoglycemia. When does that arise, firstly? And secondly, is it any hypoglycemia or is it severe hypoglycemia? Does a blood sugar of 3.8 millimoles per liter carry the same significance as a blood sugar of 2.2, for example? Then the next thing in this in the ADA-ESD guideline is a compelling need to minimize weight gain or to promote weight loss. And then the sulfonylurea is right at the bottom of this list. And the problem here is that it implies that these are very effective weight loss drugs, but they provide no evidence for what the compelling needs would be. What are the compelling indications for weight loss? What magnitude of weight loss can you expect with these drugs? And what benefit does that weight loss bring? What are the cost? What is the cost benefit of the amount of weight loss that you get with these drugs? And then again, sulfonylureas at the bottom of the list say it can be added cautiously, implying that the weight gain that you get with the sulfonylurea can be very potentially fatal. Tongue in cheek, but I mean that's the implication. So the only place that sulfonylurea finds its place at the top of this guideline is when cost is a major issue. So it implies that this inferior treatment is reserved only for the very poor. So why are there differences across the world? Why are there so many guidelines that would recommend a sulfonylurea, and particularly gliclazide, as a second-line agent add-on to metformin, and yet some guidelines relegate it to the bottom of the pile? So the first thing to note is that the two guidelines that I've alluded to, the ACE guideline and the ADA-EASD guideline, are not actually guidelines. And they make that very clear in the heading. It's a consensus report for the ADA-EASD, and the same with the ACE guideline. It's a consensus statement. And they make it clear that the recommendation presented herein are the opinions of the authors. So the elevating a consensus statement to the category of a guideline is, of course, not the author's error. It's what doctors have done. And a consensus statement, of course, escapes the rigor of a guideline and is regarded as the lowest form of evidence. So if you give a consensus statement a rating, it would be level C. And it is not recognized by the Institute of Medicine as a clinical practice guideline. So the Institute of Medicine has put out these features that would apply to trustworthy guidelines. And I won't go through each of them in the interest of time, but suffice to say that a consensus document does not fit the criteria put forward for a clinical practice guideline. And one of the reasons is that a consensus statement, of course, has variably been defined as a means that everyone agrees to say collectively what no one believes individually. So consensus can be open to very subjective feelings. So then why are these guidelines so popular? What determines the popularity of guidelines? So you could look at it from an angelic version, and the writers of the guideline would say our guidelines are popular and judged according to their scientific quality. And the satanic version to that would be that guidelines are judged according to the perceived status of the organization that issues the guideline, not the scientific quality. The second thing is that the dissemination of the guideline, what makes a guideline popular is how widely it gets disseminated. And the angelic version would be that a guideline is popular because it is disseminated based on the clinical need for best evidence amongst doctors. The satanic version of that would be that it's disseminated widely, driven by commercial need and not scientific need. So how do you go about assessing the quality of a guideline? So the AGREE-2 instrument is an instrument that has been designed to objectively assess guidelines, and it assesses the methodological rigor and the transparency with which a guideline is developed, and it evaluates guidelines in 6 different domains, and a good quality guideline would score more than 70% when judged by independent reviewers. So in 2017, the IDF undertook this very exercise, and they gave the different guidelines to different reviewers to score based on the scoring criteria shown here. And as you can see, the then ADA-EASD document scored 28% for scientific rigor and scored very lowly for applicability and resource implications as well. And so the overall score for the ADA-EASD document was 50%. The ACE guideline scored 6% for scientific rigor and an overall score of 36%. The Canadian guideline scored 81%. Now, you remember, this is a guideline that says you can use sulfonylurea as a second line and prefers glycoside-modified release. And overall score for the Canadian guideline was 83%. And similarly with the Australian guideline, also it scored 74%. The NICE guideline from the UK scored 95% for scientific rigor and 100% for editorial independence. And the overall score for the NICE guideline was 97%. So how many people have had the Canadian guideline dropped off at their offices? How many have had the NICE guideline? How many presentations have we been to where the Australian guideline is presented? Because if you're looking for guidelines based on good evidence, then those are the guidelines that should be popular. So again, it brings me to the point. The quality of the guideline, is it the quality of the science, or is it the status of the organization? And is it a clinical need for best evidence versus a commercial need? So let's follow the evidence. So firstly, the evidence for compelling indications. I don't think anyone has any argument that these are compelling indications to use the newer agents. If a patient has established atherosclerotic cardiovascular disease, if they have albuminuric diabetic kidney disease, or if they have heart failure, then these drugs must be prescribed. I will make the point, though, that for patients with multiple risk factors who don't yet have established cardiovascular disease, the only clear evidence for prevention of cardiovascular events is actually only with the REWIND study. All of the other studies in the analyses were not very good at preventing cardiovascular events in patients with multiple risk factors. The next point I'll make is that the modern sulfonylureas have proven cardiovascular safety and therefore should not be at the bottom of the pile, even for patients with cardiovascular disease, heart failure, or renal disease. And here are the points that I'll make. Firstly, the UK PDS used glibenclamide and showed long-term reduction in cardiovascular mortality. You remember that the UK PDS follow-up study showed a reduction in cardiovascular events. The advanced study, which used glycoside, showed no increase in cardiovascular events, and in fact, there was a trend towards benefit. In addition, it also showed a reduction in end-stage kidney disease by about 65% and reduced microalbuminuria and macroalbuminuria. So renal benefit and a trend towards cardiac benefit. The ADOPT study, which was a durability study versus rosiglitazone, people don't talk about this much, but in that study, glibenclamide was better than rosiglitazone for heart failure. Metformin wasn't. And then all of the observational studies that have looked at sulfonylureas, none of them have generated a safety signal with glycoside. Never. The TOSCA-IT study is another cardiovascular outcome trial that, again, has not been publicized because pioglitazone is off patent, so it's not a trial that everybody wants to talk about, but it was a cardiovascular outcome trial comparing pioglitazone with glycoside-modified release and glimepiride. And what did it show? No difference in cardiovascular outcomes between pioglitazone and these two sulfonylureas. And remember, pioglitazone does have proven cardiovascular benefit in the PROACTIVE study and in the IRIS study. The Carolina trial, a DPP-4 versus glimepiride, and showed that the sulfonylurea was absolutely safe. There was no increase in MACE or heart failure. And it had the same durability of control versus the linagliptin. And then all cardiovascular outcome trials since 2008 have all included patients with on sulfonylureas. About 40% of those patients are already on a sulfonylurea. So there is level 1 evidence for cardiovascular safety of glimepiride and glycoside-modified release. It is as safe as pioglitazone and better than the DPP-4 as a class, because remember, there are members of the DPP-4 class that increase heart failure. And insulin has also been associated with increased risk of heart failure. So to put a sulfonylurea below a DPP-4, below insulin in patients with cardiac disease or renal disease is not justified. What about the risk of severe hypoglycemia? Well, the risk of severe hypoglycemia is low with some sulfonylurea. So severe hypoglycemia, as you know, has been associated with a higher risk of subsequent mortality, but it is an association, not a causal one. It is a marker of confounding illness or comorbidity. And you'll remember that these are the randomized controlled trials, Origin, Devote, Tosca IT, and Carolina, where the comparator showed a higher rate of severe hypoglycemia, but there was no increase in cardiovascular outcomes. There was no increase in cardiovascular morbidity or mortality in these studies, despite the higher rates of severe hypoglycemia. The next thing is the hypoglycemia risk with all of these therapies. So this is a meta-analysis published recently by Rosenstock and Vivian Fonseca, looking at 24 therapies in 207 studies. And what you're looking at here is the risk of hypoglycemia. And in blue are the sulfonylureas. And you can see that the risk of hypoglycemia with gliclazide 3.6 versus 0.9 for placebo. But the risk with, say, glimepiride is 8.9, with glipizide 13.9. And if you draw a line through the risk with the gliclazide, there's no difference between, this is any hypoglycemia, not severe hypoglycemia, no difference with the GLP-1s and no difference with metformin. And in fact, I was surprised that even Julio Rosenstock and Vivian Fonseca would write in the paper, and I quote directly from them, our results show that the relative risk with gliclazide is more similar to metformin than other sulfonylureas such as glipizide. Thus, although class is important, drugs within the same class may exhibit real and important differences in hypoglycemic risk. And then I'll just allude to the Daya Ramadan study, which was published last month in Diabetes Research and Clinical Practice, examining the use of gliclazide modified release in Ramadan. And there was these are patients who were taking gliclazide modified release. They enrolled with a hemoglobin A1C of 7.5%. The risk of any hypoglycemia prior to Ramadan and after Ramadan, when patients are eating normally, there were 2 cases of mild hypoglycemia and 1 there. And severe hypoglycemia during Ramadan, before Ramadan, after Ramadan is 0. So the small risk of hypoglycemia with these drugs can be mitigated by not using them when there are these very high risk factors. And as I said, the EASD ADA document doesn't specify what the compelling needs, reasons would be to avoid severe hypoglycemia, but I've listed them there, and this comes from our South African guideline. Quickly then, let's cover the weight issue. So as I've shown you, there's this algorithm in the ADA EASD document talking about weight loss and why you should use sulfonylureas last day. So the question is there a relationship between the degree of weight loss and glycemic control? Is there a relationship between weight loss and MACE reduction? Is there a relationship between weight loss and any clinically measurable outcome? And what expectations do you have for weight loss? So this is the long-term trials with the GLP-1s showing you the extent of the weight loss, 1.27, 2.3, 1.46 kilograms in these studies. And this is the meta-analysis from Rosenstock and Fonseca showing you that the mean weight loss with these drugs is about 1.5 kilograms. You get a bit more with semaglutide, which we don't have in this country, and I'm not sure if you yet have it. So in short-term and long-term studies, the weight loss for these drugs is not very great. And similarly with the SGLT2 inhibitors in the long-term studies, 1.2 to 1.8 kilograms, and in the short-term studies, 1.5 to 2.3 kilograms. So what are the compelling indications then, reasons to lose 1.5 to 2.5 kilograms? You've got a patient who weighs 100 kilograms. What would be the compelling reason to prescribe them a drug to lose 1.5 to 2.5 kilograms, and for what clinical benefit, at what cost, and how long are you going to treat them for? Because the moment you stop these drugs, the weight comes back. And this is on top of, so the mechanism by which these drugs have their benefit on cardiovascular outcomes has recently been analyzed for the REWIND study, the LEADER study, and all of the cardiovascular outcome trials. And what it's showing us is that the dominant effect on cardiovascular outcomes comes from reducing HbA1c. Between 50 and 83% of the benefit that is seen in cardiovascular outcome trials is coming from the difference in the hemoglobin A1c between the arms. And I encourage you all to read these papers. So there's no relationship between weight loss and outcomes, but there is a strong relationship between hemoglobin A1c and outcomes. So the importance of glycemic control was covered in previous talks, but I'll just show you quickly that this is a Swedish diabetes register, 1.5 million people, looking at what are the relative importance of risk factors in type 2 diabetics for the all-cause mortality and acute myocardial infarction. For all-cause mortality, glycated hemoglobin comes out on top, just below smoking, physical activity, and marital status. So important message here is don't get divorced. If you get divorced, you're more likely to die. For acute myocardial infarction, glycated hemoglobin is the most important risk factor for our type 2 diabetics. And if you can get your risk factors, these risk factors, into the at target, you can see no matter what your age is, if you get your HbA1c, LDL, blood pressure, albuminuria, and stop smoking, then your mortality, all-cause, and myocardial infarction risk is no different to control. But the moment you start getting 1, 2, 3, 4 risk factors out of control, then your mortality goes up. And I'll remind you that this control showing this effect is in the pre-GLP-1 receptor agonist and the pre-SGLT2 inhibitor era. Again, showing you that early control, if you can get a hemoglobin A1c below 7% in the first 2 years of diagnosis, your risk for microvascular, macrovascular, and mortality 10 years later is very much lower compared to patients who have a hemoglobin A1c greater than 9% in the first 2 years. So the legacy effect shown in the UK PDS has been confirmed in this diabetes and aging study. And how do drugs compare for efficacy? This is the same Rosenstock meta-analysis showing us that in 227 trials, 121,000 patients, your HbA1c reductions for sulfonylureas, metformin, and pioglitazone are all the same, similar to your GLP-1 receptors, except when they are at a high dose, then you get a better reduction at the maximum doses of liraglutide and dulaglutide. But very much, your sulfonylureas fare very much better than DPP-4 inhibitors or SGLT2 inhibitors. So lastly, in the real world, what's happening? So cost and cost effectiveness. So cost, this algorithm implies that sulfonylureas are suitable only for the have-nots. It disempowers doctors, it disempowers patients, and it implies that you are prescribing an inferior treatment because the only reason you're choosing it is because of cost. Now, the NICE in the UK and Canada have the most sophisticated, validated, and reliable pharmacoeconomic technologies. And there is a difference between calculating what is cheap and what is cost effective. Cheap is simple. You look at a price catalog and you choose the cheapest agent. Cost effectiveness takes into account other things: clinical benefits, quality of life, safety concerns, including hypoglycemia, cost, and the resources used. And the Canadian agency in 2018, after the publication of LEADER, SUSTAIN 6, and EMPIRIC outcome, analyzed the cost. What's the most cost-effective second-line agent to use? And they still concluded that the most cost-effective drug in patients without established cardiovascular disease is a sulfonylurea. The other drugs had no clinically meaningful benefit to offset its higher cost. And these are the drugs that they were looking at. So, in conclusion, then, ladies and gentlemen, patients with a compelling indication for GLP-1 and SGLT2s are the patients with established cardiovascular disease, heart failure, and chronic kidney disease. But these constitute a minority. They make up about 20% of any diabetes practice. Early intensive glycemic control is vital to prevent complications. You need safe, effective, and easy-to-use drugs for GPs who have little time to prevent treatment inertia. The average time for a consultation in Egypt, I've looked it up, is about 7.5 minutes for your general practitioners. Much better than Bangladesh, where it's 1.5 minutes. The GLP-1 receptor agonist and the SGLT2s are not weight loss drugs. The degree of weight loss in the majority of patients is not clinically meaningful, and its inclusion as a compelling indication is not evidence-based. After metformin, sulfonylureas are the most effective and the most cost-effective additional anti-diabetic drug in both high-income and low-income countries. They're highly effective, easy to prescribe, as durable as DPP-4 inhibitors. They have a long-term safety profile, and we have more than 60 years of experience using them. And glycoside modified release has the best cardiovascular and renal safety amongst all of the sulfonylureas. The absolute risk of severe hypoglycemia with the modern sulfonylureas is very low. It's lowest with glycoside modified release, but nevertheless, we will avoid them in high-risk situations. And the default position of adding a glycoside modified release for all patients, unless there is a compelling indication not to, is a practical one, and it's one that we've adopted in South Africa. So we base our treatment on 5 principles. If there's a compelling indication, choose that drug for which you have the compelling indication. If not, consider efficacy, safety, complexity of treatment, and the affordability of the treatment. I'll leave you with this physician's prayer from Sir Robert Hutchinson: from inability to let well alone, from too much zeal for the new and contempt for what is old, good Lord, deliver us. Thank you very much.
Thank you very much. Thank you very much, Dr. Ahmoud, for this informative review about sulfonylurea. Dr. Ahmoud, I would like to thank you because you mentioned elegantly for treatment of type 2 diabetes, after metformin, you have to make a risk stratification for the patient.
Correct.
And you mentioned that there is 3 main compelling indications, either atherosclerotic coronary vascular disease, or heart failure, or kidney disease. And you mentioned elegantly that this group of type 2 diabetes are a minority, which represent 15 to 20%. But the vast majority of type 2 diabetes doesn't have this compelling indication. And here you showed us in the different guidelines, you presented elegantly, and I know you are one of the editors of the South African guidelines, the position of sulfonylurea, especially the newer ones. And you showed us elegantly in the South African, Canadian, and Australian, the position of glycoside, especially after the advanced trial. You talked elegantly about not only the efficacy, because everyone knows about the efficacy of glycoside from the advanced or the advanced on. You stated elegantly that we should start early and to control diabetes, to have the legacy effect or the tissue memory, which plays an important role with improvement with other multiple risk factors. You talked elegantly about that glycoside or the newer generations or new modalities. Concerning hypoglycemia, you showed us the meta-analysis, and it looks that hypoglycemia have hypoglycemic effects such as those with metformin. And you showed us in the DIA Ramadan that the incidence of hypoglycemia pre or during or after was less. I like the way you talked about body weight, because you showed us that the drugs which are mentioned about reducing body weight, they are not designed mainly for reduction of body weight. And the body weight, the reduction is not this so great. And we all know that the newer generation, sulfonylurea, does not gush excess insulin. That's to say, there is no this anabolic effect of insulin. Professor, I liked very much that you are still there looking for the people in the third world and those with people having a bad economy after the COVID and the cost effectiveness of the medications to treat our diabetics in our area and the whole world after this economic crisis. You showed us an important story, which I like it very much, that even when there was a comparative study between a DDB4 and one of the newer generation of glimepiride, there was no difference concerning cardiovascular outcome. And you showed us a tableau of history since the UKPDS till now that the newer generation, or even the Wanil, the glibenclamide, didn't show any deterioration of the cardiovascular deterioration function. Dr. Ahmoud, allow me to thank you again for your informative lecture. And we go back to Professor Shilbaya, the moderator of this session. Thank you again, Professor.
Thank you.
Thank you for all members of my group ESDL. They helped me so much in preparing such event, which will be completed, inshallah, tomorrow, starting also from 8:30 p.m. And also thanks to all the professors from outside and from Egypt who help us in introducing a very new updated lectures, especially about the guidelines implementations, the recent one in treating type 2 diabetes. And I'm very honored to announce that we have about 470 attendees in this meeting from different countries, from Egypt, France, Pakistan, Saudi Arabia, Emirates, Iraq, Bahrain, Yemen, and Oman. So all are welcome to attend the second event, which will be tomorrow, inshallah. And finally, I leave the last word to my colleague, Professor Muhammad Khattab.
Be with you in this meeting, and I would like to thank all the speakers, moderators of the first day meeting. Hoping to see you all tomorrow, inshallah. And on behalf of the board of the Egyptian Society of Diabetes and Lipidology, I would like to thank also the representatives of the AESD for their active participation. I would like also to thank the operators from ICOM company who shared with us tonight's meeting. Waiting to see you all tomorrow night, inshallah. Thank you all.